All right. So we are looking at digestive system this week. So let's just kind of jump in with question number one. We have here what CPT and ICD-10 codes are reported for a hemicolectomy that is performed on a patient with colon cancer. So with this one, since we're reporting ICD-10 and CPT, we can look at it either from a testing perspective or look at it from a coding from scratch. Well, either any of these we can really. But from a testing perspective, then we would find whichever option has the most that we can rule out per se. With this one's actually kind of an interesting case where there's not a single option that has the same, or there's not two options that have the same CPT or ICD-10. So from here, you would, no, sorry, you do. You have B and D that have D49.0. Does everybody see that?
Mm-hmm.
So we can go directly to CP or ICD-10 code D49.0. And we will look and see if that matches our scenario. So we're looking for patient with colon cancer. And what's our code description for D49.0? It's a unspecified behavior of the digestive system, right? So since we have the word cancer in it, we know that it's a malignancy, right? So it's not going to be an unspecified behavior. So we can automatically rule out letters B and D. And then we can look at C18.9 and C19 and see which one would most fit. So our C18.9, our code description is what for the C18.9?
Malignant neoplasm of colon unspecified.
Okay. And then what's our code description for C19?
Malignant neoplasm of rectosigmoid junction.
Yep. So which one of those codes is going to most accurately describe our colon cancer?
A.
Yep. The C18.9, because it's just the malignant neoplasm of the colon.
I have a question here. Why it says unspecified, since it's specified that it's hemicolectomy? I mean,
So the hemicolectomy is going to be our procedure. So that's going to be what our CPT code is going to signal, or what it's going to represent. So here with the diagnosis code, the C18.9, we're only looking at the condition, not the procedure that's being performed. And then our hemicolectomy, if we go look at our CPT codes, right? Let's go look at the 44140.
but my question was, I understand it says unspecified. So I get confused as specified and unspecified.
So your unspecified is just telling us that we don't have a more specific condition, right? So so our unspecified is telling us that it's just telling us that it's within the colon. But if we had more information that told us specifically where within the colon, so whether it was the ascending, the descending, or the transverse colon, right? That would be a more specific diagnosis.
Got it. So
Whereas,
it's less descriptive or less information.
Yep.
Okay.
Yep.
Thank you.
You're welcome.
I have a question.
Okay.
For testing standpoints, since this says colon cancer,
Mhm.
can we just go ahead and rule out the D49s and just look at the C's? So C's is more like cancer.
Yes and no.
Okay.
Okay. So, and the reason that I say yes and no is majority of your malignancies are going to be C codes. However, there are some like carcinoma in situs that are D codes, right? So, depending on the verbiage that they use, yes, but be cautious, right?
Okay. Yeah. Okay.
Because even because I mean, yes, technically your carcinoma in situ is still cancer, right? But you don't want to always assume that cancer is going to be your C code, right? Because depending on the verbiage, they might give you carcinoma in situ as your cancer, like as a detail a little bit later in the scenario. In this scenario, they didn't, right? But if it's like a case study, and they're giving you a long operative note and they start out with colon cancer, but then they state that it was carcinoma in situ instead of colon cancer, right? You always want to make sure that you're like paying attention to all of your verbiage.
Okay. So you're running out of time. You only have 5 questions left and you have to pick
Mhm.
one. It's okay. But
Right.
other than that, yes, definitely look
Yeah.
at them both.
Yeah.
Okay.
If you have time, you still want to verify everything else. But again, it's just one of those things that, especially if it's in 2 of your options, you don't necessarily want to always just assume that your D code is not going to be a cancer code, right? If it's in one of the options, then you can more than likely rule that one, right? But especially since like this case, if it was in 2, I would still go and just look at that really quickly. It's only going to take like 5 seconds to go and like find that and look at it and realize that it's telling you that it's unspecified behavior. So yeah.
So when we're looking at D49, it says
Mhm.
digestive system.
Mm-hmm.
And when we do the C18.9, it's more descriptive and tells you that it is a neoplasm of the colon.
Mm-hmm.
So
Right.
that narrows it down.
Right. That, and yeah, that's what we did. So the D49 again is that unspecified behavior, right? But in this scenario, they did give us the behavior because they told us that it was cancer. So we know cancer can equal a malignancy, right?
Mhm.
So that's why we ruled that one out. Is even though it does pertain to the digestive system, it's the behavior that we were able to rule it out with, right? And then that's why we chose the C18.9, is because that gives us the cancer, the malignancy at a more specific anatomic location. Okay, good questions. Anybody else have anything that they want to bring up? Okay, let's do number 2. Actually, hang on. Let me highlight this so that way you guys see that that is the correct answer. Let's do number 2 from a coding from scratch standpoint. Okay. So even though we have the multiple choice here, we're not going to look at this from a testing perspective. We're going to look at it from just a case scenario. Okay. So number 2 is we have a 7-year-old female that presents to the same day surgery unit for a tonsillectomy. During the surgery, the physician notices that the adenoids are inflamed and they must be taken out as well. The adenoids, although they're not planned for removal, are removed following your tonsillectomy. So what's our main term that we want to look up in the alphabetic index if we are looking at this from a coding from scratch perspective?
Tonsillectomy.
Yep.
Tonsillectomy.
Yep, your tonsillectomy. And then what code range does it give us in the alphabetic index underneath our tonsillectomies?
So for tonsil would be either the abscess, excision, lingual or unlisted, so we would do excision.
Well, no, if you look underneath, you've got a
Tonsillectomy, there we
tonsillectomy.
go.
Yep. You could technically go to tonsil and excision, right?
Yeah,
But yes, so you could look it up either way. So this is kind of a good example of, just because I would go straight to tonsillectomy, somebody else might see that tonsil and go to excision, right? So if we do that, look at the difference. So if you look at tonsillectomy, it gives you a range of 7 codes, right? 42820 through 42826. Whereas if you go to tonsil excision, and then with your adenoids, because we're taking out your adenoids as well, then it narrows it down to 2 options. You see that? So 42820 and 42821 versus that range of 7 codes. So it's still giving us that same area, right? It's just with the 42820 through 26, we might have to narrow it down a little bit more. So let's go look at the 42820 and the 42821.
So it's a 7-year-old.
Yep. And then we have to narrow it down by age. So we've got 7-year-old. Yep. And then we did a tonsillectomy as well as the adenoids.
So would it be A?
Yep. That would be your 42820. Now, let's say that they did not take out the adenoids. They may have noticed that they were inflamed, but they decided not to take those out. At that point, what would our code be for just the tonsils?
42825.
Yep. Yep. So if they just do the tonsils. And then if we look at the 42835, right? So if they just do the adenoids, do you know the difference between a primary adenoidectomy and a secondary adenoidectomy? Do you know what would constitute a secondary adenoidectomy?
A secondary is if they grow back and you're doing
Yep.
it again.
Yep. Yep. So there's the chance that they can take out the tissue and they might grow back. So then if they have to take them out a second time, then it would be your secondary adenoidectomy. Yep. Good job. Okay. Any questions on that one?
what is your problem?
Okay. Let's go to number 3. So we're going to look at ICD-10 and CPT here. What codes represent the creation of an opening into the stomach to insert a temporary feeding tube for nutritional support in an adult patient with proximal esophageal carcinoma due to alcohol dependence? And there's a note here that a gastric tube was not created. So let's look at this from a process of elimination or testing standpoint. How would you guys approach this from a process of elimination standpoint?
C or D?
C or D? Yep, because we've got the F10.20. Is that what you're doing?
Yes.
Yep. Yep. So that way we can rule out 2. So we can either
Yes.
confirm F10.20 or we can rule it out and know it's either A or B. Good job. Yep. That's a good starting point. So F10.20. And then once you get there, what is our code description for F10.20?
Alcohol
Alcohol
dependent,
dependence.
complicated.
Yep. So that sounds like what we've got here, right? Alcohol dependence, and they don't state that there's any complications. Yep. So we can confirm those 2 and we can rule out A and B. Okay, where do you guys want to go now?
The cancer.
Okay, so you want to go to the diagnosis code, the C15.9 or the C15.3?
Yes.
Yes.
Okay. So let's flip to those. Okay, so what do you guys think?
C 15.9.
Okay,
I was gonna say C 15.3.
okay. Whoever wants to answer, just because I asked, I'm not gonna say like Dawn or Donna, you tell me or whatever. Dana, sorry, not Donna. I was confused. I was getting ready to say Dawn, and then I decided to say Dana.
That's okay. But
So you said C 15.3, right? Is that the one
Yeah.
that you think it should be? What makes you think it
Yes.
should be the C 15.3?
Because when I went to the table of neoplasms and I looked up esophagus, below esophagus, proximal third, it's C 15.3, and then confirm it in the tabular.
Okay. Okay. And then
Okay,
Kathy,
I'm sorry. What, I missed that first part. You went where?
to the table of
Yeah.
neoplasms.
Oh, okay.
Yeah, so she did not go directly in her tabular to the code, which that was going to be a point I was going to make up, was if you weren't sure, right? Because your code descriptions are either the upper third of the esophagus or just esophagus unspecified. So if you're not sure because of the proximal esophageal portion of that code description or of the scenario, then you can always flip to your table of neoplasms, look up your esophagus. It might take a couple extra seconds, but that's fine. Go to your esophagus, and then you've got proximal underneath there, and that will give you which code it should be.
So proximal then, Tiffany is really considered upper third in a
Yes.
sense?
Yep.
Okay.
Yep. So if we think about the medical terminology for proximal,
Mhm.
right? Proximal means that it's closest to the point of attachment,
Mhm.
right? So if we're going from the top of the, if we're going from the beginning of the digestive system, which is the mouth, then it's going to be closest to the point of attachment. So that would make it the upper third. Yep. So any questions on that? Does that make sense to everybody?
Mhm.
Mhm.
Okay. So from a testing perspective, we've already figured out our answer. We know it should be letter D, right? So
Mhm.
without even opening up our CPT manual, then we've got our answer. But let's just act like you weren't sure your C 15.9 or your C 15.3, and you want to go to your CPT to rule it out. Let's go look at the difference between the 43653 and the 43830. So 43653 is a laparoscopy surgical that is a gastrostomy without the construction of a gastric tube. So our procedure is this, right? The creation of an opening into the stomach to insert a temporary feeding tube for nutritional support.
And it says a gastric tube was not created.
Right.
It won't be that
So,
one.
yep. So then let's go look at the 43830. And that is a gastrostomy open without construction of a gastric tube.
Okay.
So that would be our 43830.
Okay.
Right,
So,
Sylvia. So hang
Go
on
ahead.
just a second. Hang on just a
Okay.
second. Let me answer Sylvia's question from the chat real quick. So Sylvia, correct. We will not code from scratch on a testing perspective. And so that's why I was kind of showing you guys how to do your process of elimination. But we know that once we get into the real world, because we've got some people that have already passed and they're just doing this for a refresher. But then also I want to make sure that everybody's prepared for real world coding as well. So that's why I'm going to kind of go in between test prep questions and how we're going to rule out the answers for test prep. And then also I'm going to pull in some real world, and that's why we're using our index on some of them. Okay, go ahead, Puny, with your question.
I get the CPT codes, how it's been picked, and F10, but C15.3, so it says third. So can you explain that one more time, how proximal is counted as a third part or something?
So proximal, remember when we're talking about medical terminology, proximal means that it's closest to the portion or to it's closest to the point of attachment, right? So we know that if we're going from the beginning of our digestive system, right, that starts at our mouth, then the proximal esophagus to the point of attachment is going to be that upper 1/3. It's going to be closest to the point of attachment at the pharynx and the mouth. Does that make sense?
Yes.
Okay.
Thank you.
And then also, if you can't remember what that term means, then you can always go through the table of neoplasms, like Dana had said. She had gone through the table of neoplasms and gone to esophagus. And then underneath esophagus, you have an entry for proximal, and it gives you that C15.3. And then you would just confirm that that's what your C15.3 is the upper third.
I have a question.
Okay.
So when we're doing the CPT code, the reason we're not using 43653 is because it's a laparoscopy.
Well, we're
it's
using it for two
there.
reasons, right? Because we didn't do this laparoscopically, right?
Okay.
So we didn't use a scope, but then we also, this is with the 43653 does say without the construction. So correct. The reason that we're not using the 43653 is because they didn't specify that they did it laparoscopically,
Okay.
and therefore we have to assume that it's open.
Okay, because they both said without construction of a gastric tube.
Yep. So this is just going to test you as to whether or not you're paying attention to the detail of the scope being used or not being used. Yep. Perfect.
Okay. Thank you.
You're welcome.
And is that word opening, would that be assigned to that it would be that code that we chose versus the other one, Tiffany, or no? No, because
I'm using the open code because there's the lack of them saying that a scope was used.
Okay, gotcha.
Yep.
Okay.
Yep.
And in the note it says opening.
Right, that's how I
Right.
was saying.
Right.
Yeah.
But that
With that
opening
also-
that's here is not necessarily
It's not-
indicating
right.
that it's an open procedure.
Right.
It's just saying that an opening was created. So a stoma was created, right?
Okay.
But not necessarily. So the reason that we're using an open procedure is because they did not specify that it was done laparoscopically.
It would have to say that, correct?
Yes.
Okay.
Yep. They have to say scope, laparoscope, something indicating that there was some type of scope that was used. Yeah.
Okay.
Yep. And that goes for any scope procedures, not just in this scenario. In any scope procedures, if there's not any verbiage indicating that a laparoscope or a arthroscope or whatever it could be type scope, right? If there's not any indication for a scope being used, then you want to assume that it's an open procedure.
Okay.
Okay. Good questions. Anybody else have anything they want to chat about on that one? Okay. So for number 4, we're actually going to have scopes. Here we have what CPT codes are we going to report when a physician makes 2 separate incisions in order to perform a laparoscopic appendectomy and a laparoscopic cholecystectomy? Okay, so Jessica wants to automatically go with the one that says the 59, right?
I would say A or B.
Okay, so
B.
A or B.
I would say C.
Okay, so we've got a little bit of like everything, right? Okay, so let's look at this from a testing perspective. Okay, so let's look at, so Sylvia, you're saying the 44970 is for the laparoscopic appendectomy, is that what you're saying?
Yeah.
Okay, yeah, yeah. So you can look up this one. You've got two options that have 44970. Okay. So let's go look at the 44970. Now, Jessica, is it Jessica? I think it was Jessica. Yes, Jessica. You're not wrong in your 59. But you want to be very cautious with just assuming your modifier is going to be your only indicator. Okay. You always want to at least make sure that you can go with your gut and say you're 59, but you still want to verify your codes. Okay. So let's look at that 44970, which is again, yeah, your surgical laparoscopic appendectomy. So that one is that. And then so that one's that one. And then your 47562. I don't know why I'm having such a hard time navigating these codes tonight. 47566. My brain is like struggling with this tonight for some reason. Yes. Laparoscopic surgical cholecystectomy. Okay. So then again, from there, we can say, okay, we know it either has to be 51 or 59 on that second one, right? And then we know that our code descriptions for 51 versus a 59 is multiple procedures versus separate and distinct procedures. So correct. Yep. So we would go with D for the 59.
I
Now,
have a question. I have a
yep.
question. So we're saying it's it's modifier 51 because because it's being done at the same time. It's not like for 59, let's say that would be like if you're doing an appendectomy and a tonsillectomy. That's two distinct.
Well,
right?
no, this one we're saying the 59 is the correct. 51 would be if it was through the same incision. Okay, if it was done like in the process of doing another procedure, that would be a 51.
Okay.
59, since we're doing two separate incisions, that's what's
Okay.
telling us that we need to use the 59.
Okay.
Now, when I say we're in the same incisions, it would be a 51. Okay, this is where it gets a little tricky. Do you guys know what an incidental appendectomy is? Does that phrase ring a bell for anybody? Incidental appendectomy?
No.
Okay. So if they're going in and let's say they're performing a colectomy, okay? They're not doing a cholecystectomy, but they're doing a colectomy, something that's in that general area, right? So they're pulling out a portion of the colon. While they're in there doing the colectomy, they realize that the appendix is inflamed and they decide to take out that appendix before it starts to become a problem. Then that's going to be what's known as an incidental finding. Okay, so it's going to be an incidental appendectomy. So if that is the case, and this only goes for appendectomy, okay, If that is the case and they happen to find the inflamed appendix in the process of another procedure, you will not code your appendectomy separately. It's going to be included in the initial procedure.
So you won't use a 51 then?
You would not code the code, period.
Wow. Okay.
And the reason for that is because in order to do an appendectomy, it takes like a total of 3 minutes once they see the inflamed appendix and they go in and they decide to do the appendectomy. It takes like a total of 3 minutes. It's a very quick procedure. So they don't really consider that a separate procedure. Okay. Like I said, that only goes for your appendix. It doesn't go for anything else. It's only your appendix that you would not code separate if it's an incidental finding. So if this was done during the same incision, then your only code would be 47562. You would not code your 44970. You would not code this separate. Okay. I know that can be a little confusing, but it's a very common occurrence in the real world that you'll see a certain procedure being done in the abdomen, and then they determine that your appendix is inflamed and they decide to go in and take it out. So in that case, if it's an incidental finding, again, it will not be reported at all. And you would only report the initial procedure that they went in to do. Does that make sense?
Mm-hmm.
Yes.
I just want to make sure that everybody understands that, because like I said, you may or may not see it from a testing perspective. But real world, it is a pretty common thing that you'll see. So I wanted to just kind of touch on that.
I have a question.
Okay.
Okay, so D is the answer.
Mm-hmm.
And in the question, it says appendectomy and then the whatever that is.
Cholecystectomy. Yep.
Thank you.
Yep.
Does the 47562 have to come first before the 44970?
Yes, because your 47562 is going to have a higher RVU value.
Thank you.
You're welcome. So from a testing perspective, they're typically going to go ahead and list those in RVU order. So you shouldn't have an option that has 44970 and then 47562 with a 59, and then you have to choose between the two. Your correct answer should be obvious once you have gotten your correct codes.
Okay, great. Thanks.
You're welcome. Now,
So
you will have to remember your sequencing from an ICD-10 perspective with your guidelines, but your CPT codes will typically be already in your RVU order.
Okay.
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 So they won't give us as a 47562 in one as a first and the other one 44970. They will give us in the same RVU order, right? For CPD purpose?
Right. Yep. So you should not have something that looks like this. You should not have 44970 and then 47562 with a 59. You won't have to make this determination.
Okay.
Right.
Okay.
They might have like this where they have the 44970 second, and then you have to determine between a 51 and a 59. But it's not going to be like having these two switched, and then you have to determine yourself during a testing perspective which one has the higher RVU. Okay.
Thank you. Thank you.
You're welcome.
Hey, Tiffany.
Yes,
Can
ma'am.
you explain the 51 and the 59 again? It's like a little confusing. I know you said the 51 is done through the same procedure, means same incision, correct? And 59 is done on two different areas. Am I saying that right?
Essentially, that's the best way to very simply put it. Yes.
Okay.
Yeah, it's one of those things that it depends on if there's two separate incisions, that is 100% a 59. You should never report a 51 if you have multiple incisions. Okay.
Okay.
You
So
can have a 51 during the same incision. Okay. But it all depends on your verbiage and like if each one of those procedures are kind of part of each other, but different at the same time, if that makes sense.
yes. So for
Okay.
example, like lesions, like if you're removing lesions from the arm, the forearm, or the face, those would be like 51 code, like 51 modifiers then?
Those would actually be 59 because those are
Yeah.
going to be per lesion.
Per lesion. Okay, got it.
Yes. Yeah.
Makes
So
sense.
those would be because those are separate and distinct lesions. Yeah.
Okay.
So those would
got
be
it.
59s.
Okay, got it. That makes
Okay.
sense now. Okay.
Perfect.
Thank you. Yes.
You're welcome. I know 51 and 59 are so similar yet so different at the same time that there's still some times where I have to sit back and think, should I use a 51 or a 59? So
Okay, got it. But it makes
just when you think you've got it, you don't. And then you'll
yeah,
have
that's
to
what
like
just
second
happened
guess
to
yourself.
me.
Yeah.
It just happened to me too. That's why to make sure I'm like, what? Okay.
Yeah. Yeah. I
Thank you.
promise one day it will start to make sense a little bit more and then you'll find yourself thinking about it less and less. Yeah.
Okay. Thank you so much.
You're welcome. Absolutely. Any other questions? Okay. Let's look at number 5. So number 5, we have a patient presents with a 2 centimeter benign lip lesion. The provider decides to remove the lesion along with a portion of the lip by performing a wedge excision. So single layer suture is then performed. So what CPT code or codes should we report? Okay.
40510.
Okay. So did you already look up the code description or are
I
you?
did.
Okay. Okay.
I
So we
did.
know that the 40510 is our procedure for the wedge excision for the lip. Yep. Okay. So the main question is, do we code the repair separately or do we only code the 40510?
No, because it says with primary closure.
Yep. So if they had said that they had done a layered closure, would we report that separately?
Yes.
Yep.
Yes.
Yep. So all of our procedures should include just your simple single layered closure. Yep. But if you do have to report a multiple layer or full thickness or anything like that suture repair, you would code that separately. Good job.
So you
Any
don't
questions on
include
that?
the removal of the lesion?
No. When you have excisions, full excisions, and then repairs that are done, actually, no, your 40510, the code description is the excision itself. And then your excision includes your primary closure.
And this is a question that is on the test, or a similar question to this is on the test.
Yeah. Yeah. There's a lot of questions that come from the AAPC test bank that they give us that have been found on the exams. And if they may have a different measurement, right? They may say a multiple layer or a layered closure instead of, a single layer. But yes, these are there's the high chance that, you might see questions that are similar to these. Yeah. Okay. Any questions?
They kind of fool you when they say CPC codes versus code.
Exactly.
So
Yep. That's why they say code or codes is /R. Yep.
Yes. Mm.
Yep.
So I have a question.
I think on this question, I'm sorry. I
Go
think
ahead.
on this question is it's partly about guidelines.
Well, this one,
On
it's
repairs.
directly in your code description that it includes primary closure. So this
Yeah.
one isn't necessarily a guideline per se. This one, it directly says in your code description with your primary closure.
Yep.
Okay. What were you about to say, Puny?
So I know it says primary closure. So a single layer is a primary closure?
Correct. Yep.
Okay.
Okay. Any other questions?
This isn't a
I'm just-
question, but I just find it weird that the lips are in the digestive system. When I saw this question, I automatically wanted to go to, you know,
Your
1-1.
integumentary. Yeah.
Yeah,
Yeah.
totally. So that threw me off, but good to know.
Yep. Yep.
So I
Yep.
have one more
Just think.
question.
Okay.
So primary closure is a single layer. So what about full thickness and all those? Are those multiple layers?
Yes. Yeah. So if you have a full thickness, that's going to be considered an intermediate closure.
Thank you.
You're welcome. Okay. So let's do number 6. So what CPT and ICD-10 codes are reported for a gastric restriction by placing a gastric band via a laparoscopic surgery for an adult patient that's diagnosed as morbidly obese, having a BMI of 43, type 2 uncontrolled diabetes, and then elevated blood sugar readings daily. So where do you guys want to start?
Z
So
code,
let's look sorry, go ahead.
the Z68.41 is
Okay.
common in all, but that wouldn't.
Yeah, so in that case, if you have a code that's in all 4, I would recommend starting with another code to eliminate.
The E10 or
Okay.
11.
Yep, E10.9 versus E11.9. Okay. So what's the difference between the E10.9 and the E11.9?
One of them is diabetes 1 and the other's diabetes type 2.
Yep, perfect. So in our scenario, what type do we have?
Type 2.
Type
Okay.
2. Mhm.
So what is our ICD-10 code that we're going to use?
11.9.
Yep, the E11.9.
Years.
Okay, let me ask this. What if they just said patient has uncontrolled diabetes? What would we default to?
Type 2.
Correct. So Lori, you are not incorrect. I have argued this with AAPC and they keep telling me that they're not going to update this because it is uncontrolled. This should technically, so in a real world perspective, E11.9 should technically be E11.65. Because if you look in your alphabetic index and you go to uncontrolled, then it gives you E11.65.
That's what I got too.
Yep. Yep. But from a testing perspective, if they do not give you E11.65, choose whatever is closest and move on. But from a real world perspective, yes, 100%, it should be E11.65. I'm glad you brought that up. I wasn't even about to go on my high horse about that one, but yes, it should be E11.65. Okay. Where do we want to go next?
CPT codes
Yep.
438 and 43770.
Yep. Because we've ruled out as much as we can with ICD-10, right? They both have E66.01 and Z68.41. Okay. So the best way to now find your correct answer the quickest is going to be go to your CPT codes. So 43842.
It'll be C.
Okay. So 43842 is for a gastric restrictive procedure without gastric bypass for morbid obesity. And it's for a vertical banded gastroplasty. And then our 43770 is for laparoscopic, surgical, gastric restrictive procedure, and then placement of that adjustable gastric band here. So yes, perfect. So it should be 43770. Yep. So really, we only had to look up 2 codes out of all 4 of these to quickly find our answer. But we know that E66.01, well, I don't know that we all know it. I know it because I've looked at these codes 850 bajillion times, is your morbid obesity. And then the Z68.41 is the BMI of 43. But like I said, from a testing perspective, we really only had to look up the 43770 and the E11.9. Any questions on that one? Okay. All right, let's go through this last one real quick, number 7. So we've got a patient is seen in your gastroenterologist clinic for a diagnostic colonoscopy. While performing the service, the physician notes a suspicious looking polyp and removes 3 using a snare technique, and they sent those to pathology for further testing. So let me ask you guys this before we even start coding. If we do a diagnostic colonoscopy and then it is converted and they actually perform a procedure, are we going to report the diagnostic as well as the surgical?
Just surgical?
Yep.
Mm.
We should only report the surgical, and that's with any scopes. Your surgical scopes, whether it be an arthroscopy, a colonoscopy, a laparoscopy, whatever it is, our surgical is always going to include our diagnostic. Yep. So we know that we're only reporting 1 code, so we can automatically rule out C and D.
It'd be A.
Yep. And then we just need to go look at our code descriptions and decide if it's the 45385 or 45380.
It's A because it was a snare used.
Yes. Yep. Because the 45380 is just a biopsy, whereas the 85 is with the removal of tumor, polyps, or other lesions by a snare technique. Yep. So since we removed 3 polyps using that snare technique during the during the colonoscopy, then it would be your 45380. Okay. Any questions that you guys want to chat about for the last couple minutes?
So I have a question. So any surgical includes diagnostic?
When you're talking about scopes, but yes, more than likely. So especially if you have like a exploratory laparotomy, right? If once they get in and they're doing that laparotomy and they find something and they have to perform a procedure to repair, to fix, to excise, to do whatever, then at that point you would only code the surgery that was performed, not the exploratory or the diagnostic. Correct.
Thank you.
You're welcome. Any other questions? You guys had some really good questions tonight.
Hi, Tiffany. My name is Dawn. I just joined the group and I like the way that you break everything down. It's very informative.
Good. I'm glad you're getting something out of it. That's why we do it. Because we noticed that a lot of people were struggling with courses that they've taken where they didn't really break it down, right? So that's why we decided to do our study groups and just kind of get everybody together and make it, easy to comprehend. That way you know what to pull out And then, that way too, we're not only just focusing on test prep, we're focusing on potential real world things that you might see and how to use your book and how to find things. Because that's the hard part, right? Everybody can look at a multiple choice and eventually get the right answer. But the hard part is using your book and actually coding from scratch when you don't have the answer already there in front of you. So good. I'm glad you've joined. I'm glad that you're finding it beneficial. We're here. Any questions that you have, don't hesitate to reach out.
I have a question on number 6.
Okay.
Okay, so when we're talking about unspecified diabetes, and you said there's an unspecified code, what was that unspecified code again?
Well, if they don't specify the type of diabetes, is that what you're talking about? If they just state that the patient has diabetes, is that what you're talking about?
Well, when I answered the question on 6 and you said, what do you defer to if it doesn't say what type? And I said E11.9, but then somebody else came in and said there was another code, but apparently they're not using that on the test.
Right.
And I don't have the new book. I mean, I'm working out of 23, so.
Well, the E11.65 is also in the 2023. So what we were talking about, we were kind of having 2 separate conversations with that one, right?
Okay.
So if they don't state the type of diabetes, your ICD-10 guidelines tell you and they instruct you. If they don't specify the type of diabetes, we should default to type 2.
Okay.
And then the other conversation we were having is if you look in your alphabetic index under diabetes, okay, I'm going to look with you. I'm going to pull out my 2023. So that way we're looking at the same one. Do you have the AAPC version?
I do, yes.
Okay.
Well, I have the AMA version.
Of the AAP or of the ICD-10?
Yes.
Okay. So if you look at diabetes,
Okay.
and then underneath diabetes, you have uncontrolled all the way down at the bottom, underneath your different types,
Okay.
right?
Mhm.
Underneath do you see that uncontrolled option?
Yes.
Okay. So it either tells you hyperglycemia or hypoglycemia, right?
Yep.
So here, the scenario is telling us that they have elevated blood sugar readings. So that's hyper,
Yep.
right?
Mhm.
So we should go look at diabetes by our type and then with hyperglycemia.
Okay.
So if you go underneath diabetes, type 2, and then hyperglycemia, what code does that give you?
E1165.
Yeah.
Okay.
So that's why I was saying from a real world perspective, if they tell us that it is uncontrolled and there are elevated blood sugar readings, it should be E11.65 instead of E11.9. But from a testing perspective, if they don't give you the E11.65, then just go with what is the closest.
Because that's what the guidelines tell you, and you go by what the guidelines say.
Yeah.
Okay. Okay.
Like I said, I have kind of argued this with AAPC a couple of times, and they keep telling me, no, E11.9 is not wrong. And I'm like, but it technically is. So from a testing perspective, if they only give you type 1 or type 2 unspecified, then you would go with your type 2 with no complications, right? But technically that elevated blood pressure or that blood sugar reading, that's technically a complication because it's not controlled.
Yeah, and I think they're coming at it as a standpoint of, are you paying attention to the guidelines?
Right. Right. Yeah.
Thank you.
You're welcome. Absolutely.
I really enjoyed this. It was really very, very good. Thank you.
Good. Good. Any
Tiffany,
other
I have a
questions?
question.
Yeah, absolutely.
Okay, this is with regards to the exam and going to take it.
Okay.
Will they allow you to bring Kleenex in with you or not?
Like just regular like tissue, like facial tissue?
Yes, because I have like severe sinus issues going on and I can't stop blowing my nose. I hate the idea of having to reschedule this test next week,
Right,
but if I'm
right.
not better by Friday, I don't see any other way if they're not going to let me have tissues. Like I didn't know.
I would say when you get there, I don't want to say yes or no because every testing site is going to be different, right? They may, as weird as this sounds, they may allow it. They probably will, depending on your proctor. They will just investigate your tissues. Like, as weird as that sounds, they're just going to want to make sure that you don't have anything written on them, you know, all of that kind of stuff.
Oh, I'm totally fine. Like I'm willing to take them out of the box and
Right.
everything.
Right. That's what I'm
I'm
saying. Like, they may be as picky as saying, we just want to make sure there's nothing written on them. And they may say, take out 4 or 5. And then if you need more, you can come out and get more, you know, obviously, one of those things. But it just like, that's why I hate saying that it should be allowed. Because I mean, you would think common sense would say it's just a dang tissue, right? It's not like I'm bringing in
I
scratch paper
know.
and I'm going to write and erase and all of those types of things. But every proctor and every testing like center is going to be completely different. So I would hate to tell you, yeah, absolutely, you shouldn't have any problem with it, because I know as soon as I do, you're going to get that one pain in the chookus proctor
Yeah.
that is going to be super specific and say, nope, it doesn't say on the allowed list of, you know, references that you're allowed to bring in tissues, you know, type thing. Worst case, there may be like, you can probably call AAPC and ask them and kind of explain it, and they may just kind of like notate it on your account that, you know, whatever. Like if you have a doctor's note, if you went to the doctor, I don't know if you did, because I know you said that like your kids and stuff have been so gracious
Yeah.
in passing it around.
Well, not only that, I can't take anything because I'm
Right.
breastfeeding.
Exactly. Exactly.
That's
Yeah.
my other problem. Like it's not like I want to be sick and
Trust me, I
continually
know.
having
Yeah.
my nose, but a decongestion is not an option.
Is
So
not even an option. Yeah. Worst case, when are you taking your exam?
I'm supposed to take it Wednesday next week.
Wednesday of next week. Are you in good with your doctor? Like, can you call up your doctor and say, hey, I'm taking an exam? Can you just write them a note and say, I am like suffering with a head cold? And like, would they be willing to write like just a quick doctor's note for you? Do you think?
Funny thing is I haven't seen like my regular doctor and I couldn't tell you when.
Okay. No, you're fine. I didn't know if like you had like an OBGYN, you know, with all of that.
Well, my OB I probably could, yeah.
Yeah. See, your OB would probably be a lot more willing to do it because they obviously are going to say, do not take a decongestant, right?
Right.
Call them and see if they would be willing to just write you a quick note and then call AAPC and be like, look, I know this is overkill, but I just want to make sure I've got all of my bases covered. And it's not like you're asking for like a time extension or anything. So they should more than likely, they should more than likely like say you are good, I promise, tissues, like you're not gonna like struggle with that type thing.
Well, and here's the funny thing. I was also considering calling them and finding out because I am breastfeeding like
Yeah.
4 hours without feeding my little guy.
You could probably get an approved break because of that. You would just need to have somebody like a doctor write a note.
Okay.
And you should be able to get that approved for like a medical break and it not count against your time. Yeah.
All right. Yeah, because that's been stressing me out thinking about it as well.
Don't let that part stress you out. Worst case, or you're in person, right? You're doing one at a testing center. Yeah.
Yeah.
Worst case, if they tell you, call them first thing in the morning. Okay.
right.
Call them first thing in the morning and see how long it takes for that medical accommodation to be approved. And if you need to push it out like a week just to make sure that you have that medical accommodation so that you can get that break in there. Then if you have to, like I said, if you have to push it out a week, I know it's not ideal, but I would much rather you push it out a week to get that medical accommodation than to suffer because I know that that's not like, it hurts. I know.
Yeah.
Um,
Yeah.
so yeah, see if you can get like either your OBGYN or even a pediatrician or something to write a note for you and just
Okay.
say, like you gave birth however long it's been, and you're pumping and you're doing all of those things and feeding and all of that. And
Okay.
see if they would be able to write a note for you to be able to submit to AAPC to get that accommodation approved.
All right. So then call AAPC in the morning.
Yes, they will be the ones to approve it and give you the instructions of who you need to get a note from, and what type of like documentation you need to submit to get it approved.
Okay, awesome.
Yeah.
Thank you.
You're very welcome. Sylvia, so to answer your question as far as water to drink and all of that, you cannot take it into the testing room with you, but you can have it out in your locker just outside of the room, and you can go and get a drink, or if you need to, you can go to the restroom, but it does not stop your time. So if you, and believe it or not, it's one of those things that when you're testing, you're not going to sit there and think, hey, I need to take a drink of water, right? It's not going to be like that normal, like you're just sitting and working or you're sitting around the house or doing whatever. You more than likely would probably only take 2 sips out of your water anyways. So just kind of keep that in mind. And then as far as like I said, your bathroom break goes, as long as you don't drink and you don't down a gallon of water an hour before your testing time and your appointment, then usually you can go and you don't even think about going to the bathroom. Like that time will fly faster than you guys think. So don't worry about not being able to bring in something to drink or go into the bathroom. But obviously, if you get parched, then you can go out and get your drink or whatever you have, or you can run to the restroom. But just keep in mind that it does not stop your time. So you want to make any breaks that you take very quick.
So I have a question, sir. Like when we read a question, we'll be able to highlight things and all that, just like a crayon on the top like this, or can we carry pencil or something?
Well, so it's all on the computer. So your testing environment is in a software, and it does give you the ability to highlight, but it doesn't give you the ability to highlight in different colors. But it does give you the ability to highlight in yellow. And then you have a notepad that's worked into that testing environment as well. So you can make notes in that little notepad. You can type out notes, and then you can highlight whatever you want within your scenario.
Okay, thank you.
You're welcome.
So the practice exam would be the same concept?
Correct. Yes, if you get an AAPC practice exam,
Mhm.
those practice exams will look identical, like format wise, not question wise, obviously. But format wise, your testing environment from a practice exam standpoint is the exact same as what you would see in the testing environment.
Okay, I see. Thank you.
You're welcome. Any
I can tell you,
other?
I
Go
can
ahead.
say that when I took my test, they gave us a little bag of goodies with different things like erasers, and they gave us, I think they gave us a little thing of Kleenex actually. I mean, it
Did
depends on the proctors.
Did you
They
take
also
yours
gave
in
us a notepad
2023?
and a pen.
Did you take it in 2023?
Yeah.
Yes. So those days are gone, unfortunately.
Oh,
The
okay.
proctors that you get with CPC exams and any AAPC exam now, they are not certified instructors. They are like testing facility employees. So
Oh,
they
I see.
are, yeah, so they are employed, and you're not even having anything to do with anybody that is related to AAPC.
Okay.
Yeah. So unfortunately, we used to be able to do that whenever we used to be able to proctor in person, and it was on paper, and all of the days of the Stone Age. But yeah, unfortunately, since they moved it to all electronic, then the capabilities are, I guess the flexibility is gone.
That's really too bad.
Yeah. Charmy, you can take your AAPC practice exams as many times as you want, as long as you're within that 1 year time frame of your purchase. You can take any of your AAPC exams. If you want to take them 50 times, you can. Now, it's not going to be beneficial after you take them so many times because you're going to eventually remember the questions. But if you get multiple practice exams, then you can take them more often, right? Because once you get to practice exam D, you're not going to remember the questions that are on practice exam A. But yeah, you can take them as many times as you want. And the nice thing is after they're graded now, they actually give you your percentages and your areas of weakness. So that it actually breaks it down so you know what areas to still kind of touch on and study. Okay. Any other questions? Anything else you guys want to chat about? Some good conversation tonight. All right. So next week we will go over this 50,000. So that's going to include urinary and all of your reproductive, including maternity and delivery and all of that kind of stuff. The questions are already in the Google Drive, so you guys can go out there now and start looking at those and getting familiar with those. But if you guys have anything between now or next week, you can either put it in the Discord chat, you can private message me on Discord, post something in the Tiffany Roach Coding Coach group, wherever it is that you found out about us. Just don't hesitate to reach out wherever you guys are. Jessica, now that it's digital, the chances are very, very low. Very low. When it was all in paper, the chances were a little bit higher because they were chosen at random. But now since they're digital, they can see what version you had last time and they can make sure that you don't get it again, unfortunately. Okay. All right, ladies. Well, if you guys have any questions, like I said, don't hesitate to reach out. Have a good rest of your Wednesday evening, and then I will chat with you guys next week. Have a good
Thanks,
night.
Tiffany.
Thanks.